for inviting me. I wish we could all meet in person. It would be more interesting. We can keep it interactive. That's usually how I do this. But given the circumstances, we have to do it this way. I hope it doesn't be one of those things where I drone on and on. I've mixed up the slides so that you talk about different things that will keep your attention. And I'll check the chat box, and Linda would also be checking that. So if you have any questions, please feel free to ask. So with that being said, I wanted to kind of talk about MS and a couple of other diseases that can present like MS, but the majority of the focus will be on MS, since that is the most common of the demyelinating disorders. What is MS? It's an inflammatory demyelinating disorder of the central nervous system which causes destruction of myelin and axons as well. So the CNS includes the optic nerves, the brain, the spinal cord, which is all the upper motor neuron system. Now, the prevalence of MS is not uniform throughout the world. There are certain parts where it is much more prevalent. And as you can see in this picture here, the highest prevalence is in North America and Western Europe. And when you go to some parts of Asia and Africa, it becomes very, very less. Now, there are both genetic and environmental causes for this. Obviously, genetics plays a role, but certain things in the environment seem to trigger this as well. So if you look at the risk of somebody having MS, it looks like where they grew up the first 14 years of their life, that seems to make a difference. So that shows us that, in terms of incidence, it's not just genetics. Environmental factors play a role, and especially environmental factors early in life. So let's say somebody grew up in Africa and migrated to the US at age 30. They still carry their low risk of MS with them because they grew up in a low incidence area the first 14 years of their life. On the other hand, if you have somebody from the US going to Asia or Africa, they do carry that high risk with them if they migrated after 14 years. So along with genetics, it's the early environmental factors that seems to play a role in someone developing MS. We just talked about this. We know there is a genetic predisposition based on twin studies. The general risk of somebody having MS is about 0.4%. If you looked at monozygotic twins, that risk goes to 30%. So if one twin got the disease, the risk of the other twin getting is about 30%. That's a lot higher than the general population, but on the other hand, it's not 100%. So that 70% is accounted for by environmental risk. Now with the GWAS and all that, more than 100 risk genes have been identified that predisposes one to risk of getting MS. Now the risk for MS isn't for MS alone. Often the genes that are on HLA-DR2, they carry a risk of any kind of autoimmunity. And what among the autoimmune diseases somebody develops seems to be probably what triggers that disease. So the risk of autoimmunity goes to together rather than specifically MS alone. Moving on to environmental factors, what have we looked at? Infections are the number one, especially viral infections have been looked at quite extensively. Recently, we had a couple of papers that again emphasize the risk of EBV or infectious mononucleosis. It's a little difficult because more than 90% of the population tests positive for mono. So with something that is so prevalent, how do you attribute a risk of MS to that? So even when you look at the infection, it seems like it's not if you got the infection, but when you got the infection that seems to play a bigger role. So there is a lot more to be studied there. When we come into certain environmental organisms that as our immune system changes with time, it may be certain time points that response from the immune system to infection puts a patient at a higher risk versus the same exposure at a different point in the maturation of the immune system. The other thing that has been looked at is gut microbiome. That is getting a lot of interest, whether it is some kind of bacteria that inhabit the gut that releases some kind of toxins that go in and break the blood-brain barrier, and that is what causes this. Vitamin D has been looked at a potential risk, especially in pediatric populations. Patients who have a low vitamin D level have a higher risk of MS, and this has been studied in kids too. Along with the higher risk of getting MS, it's also a risk of disease progression in MS. Cigarette smoking, like so many other diseases, it's been associated with a higher risk as well. Now, when you look at the pathology, how do the lesions look on MRI? These brown areas are the lesions. These white parts are the white matter. Most of the brain is actually white matter. The gray matter is the nuclei that are along the cortex, and then they communicate with one another across all which way through these white matter tracts or axons, and that forms the bulk of the brain. And since MS predominantly affects the myelin, most of the lesions are in these major white matter areas. Now, if you look at it at a microscopic level, the initial inflammation happens around venules. So it's lymphocytes or other immune cells that migrate from the tiny venules that grow into the substance of the brain and then cause the lesion. So first you see all these immune cells around the vessel wall, and then gradually they migrate out to cause the lesions. Now, how does one diagnose MS? The peak age is about 15 to 45. Actually, the mean age is about mid-20s. So patients are diagnosed quite early. It's often a disease that affects the young population. When you look at the ratio of women to men, most autoimmune diseases like lupus or something, the ratio is much higher. It approaches 8:1. With MS, it tended to be low, but now that incidence seems to be gradually increasing over time. It's more common among Caucasians, but that is also changing. Going back to an earlier slide I showed where the incidence was very low in Africa or some parts of Asia, African Americans have a much higher incidence, and the newest studies looking at incidence, they actually said it's comparable or even higher than Caucasians. So even when I was doing my fellowship like more than a decade ago, it was like, if we diagnosed an African-American patient with MS, they would be like, Doc, isn't this very uncommon? Even that has changed even over a decade where the incidence seems to be much more higher. Now, the brain controls pretty much all functions, whether it's sensory, motor, vision, bowel bladder. So the symptoms of MS can be any of these things, depending on where the patient developed the lesion. Now, with regard to what might you see on exam in a patient with MS, again, since it can affect so many tracts, so many functions, it can affect any of these cognitive effects, cranial nerve deficits, motor deficits, sensory, abnormal reflexes. But what is very, very important to remember is, especially earlier in the disease or milder disease, even later in the disease, the patient can have a completely normal exam between relapses. So a normal exam should not exclude a diagnosis of MS. Once we suspect MS, how do we confirm that this person has MS? The most important are the MRIs, brain and spine. Since it can affect the spinal cord too, we get MRIs of the cervical and thoracic spine as well. The rest of the stuff, earlier, everybody who was diagnosed with MS, they ended up getting a spinal fluid or a lumbar puncture. We don't need that now. Only if the MRI is not conclusive enough and we need more evidence to make the diagnosis, we do a spinal tap. But for most part, most people who are diagnosed with MS do not need LP or spinal fluid. Blood test, again, in the appropriate setting. If you suspect that they have lesions in the brain or spinal cord because of lupus or because of some other autoimmune disease, then you would do it. But it's not necessary in every single incidence to do the entire retinal blood test before you make a diagnosis. Evoked potentials were again used much more in the past. It's really not used that much anymore. So going back to the MRI, which is the most important tool in terms of making a diagnosis of MS, how does an MS lesion look? So if you look at these scans, you can see that they are kind of ovoid. Their long axis of the lesion is perpendicular to the long axis of the ventricles. So when you see lesions like this that are, prominent, they're not tiny, they are ovoid, and the long axis is aligned, crossway to the ventricle. They are very typical lesions. So in somebody who, let's say, presents with numbness or problems with vision, and you get an MRI like this, you really don't need to do the spinal tap. This is enough to make a diagnosis of MS. Same thing if you look at, because the corpus callosum is the largest tract of white matter, so obviously MS lesions are going to be seen prominently there. And when you look at lesions on a sagittal cut, it looks like they are fingers sticking up from the surface. That is because the veins in the corpus callosum are aligned that way. So the lesions also tend to look like these sticking up. So they're called Dawson's fingers. They're also, now these lesions are very typical for MS as well. So if you see lesions like this, again, you don't need the spinal tap. Moving on to what might the spinal cord looks like. You see an MS lesion here. This is sagittal cuts. You see the lesion now. It's important to pay attention to how this lesion looks compared to something called NMO, which can also affect the spinal cord. I have a slide that will kind of highlight the differences more. So this is again an MS lesion. Each lesion is not that big. And on a cross section, it doesn't cover the entire cross section. It's a partial transverse myelitis. Same with GAD enhancing lesions. So GAD enhancement happens when you give IV contrast to the vein. So if a lesion is being newly formed, you have these immune cells that cross from the blood into the brain by crossing what we call the blood-brain barrier. Now, when a lesion is being formed, these immune cells go into the brain, cause these lesions. The brain patches it. So in about a month, if you repeat the MRI, that particular lesion will not be taking up contrast anymore because the blood-brain barrier is sealed up. But if you're looking at a lesion that's fairly new, within a month of being formed, then you will see it, then it shows up as a GAD-enhancing lesion. So GAD-enhancing lesions actually increase the specificity of it being MS rather than just non-GAD-enhancing lesions. So this is what I was alluding to earlier when I said we need to look at how the spinal cord lesions look in helping distinguish MS and neuromyelitis optica or NMO. So these are MS lesions. If you look at an individual lesion, it covers pretty much one vertebral segment. If you look at NMO, the lesion extends 3 or more vertebral sections longitudinally. And on cross-section here, the MS lesion covers about half, or it doesn't cover the entire cross-section of the spinal cord versus an NMO lesion that covers the entire cross-section. So if you see lesions like this, even if they have lesions in the brain that look like MS, you should still suspect NMO and send for the NMO IgG antibody. So these are differences between MS and NMO. Relapses seen in both of them, but in MS, it can pretty much affect any part of the brain or spinal cord. With NMO, the clinical presentations of optic nerve involvement or spinal cord. Most patients with MS have relapsing remitting. There is a small progressive cohort. You don't tend to have that in NMO. patients have problems or have baseline deficits because of residual from relapses rather than a progressive course. The age of onset seems to be slightly older in NMO, and the female to male ratio I had mentioned to you before. In MS, it tends to be lower than the usual autoimmune thing where the female preponderance is much higher. Recovery from relapses, MS is pretty good. NMO, often these patients, these are the folks that end up getting Plex or IVIG after steroids, corresponding to how their MRIs look. Those lesions are much more drastic, might need a lot more than steroids for them to recover. Disability we talked about. Lesions, you see typical lesions in the brain for MS. Initially, when they defined NMO or Devick's disease, as it used to be called, they said, you know what, you cannot have any lesions in the brain. You should only have lesions in the optic nerve and spinal cord, but that has evolved. It's changed over time. So now it really doesn't matter what the MRI of the brain looks like. Even if they have lesions that look like MS, if they are clinical presentation, or if they are spine MRI, or if they are optic nerve, if the entire optic nerve is inflamed, still think of NMO and send a blood test for that. We talked about the spine. CSF, oligoclonal bands and IgG index is elevated most of the time, more than 95% of the time in patients with MS. It's very, very uncommon in patients with NMO. So when your, patients can present very differently, we can collect all these tools to kind of make the correct diagnosis. Another differential is called ADEM. It's acute disseminated encephalomyelitis. How do we differentiate that from MS? When you look at the MRI in ADEM, the lesions tend to be a lot bigger. They look fluffier and rounder. And because ADEM is a whole bunch of inflammation happening all at once, all of those lesions tend to enhance with contrast. So that's why I was mentioning why a lesion would enhance with contrast. So new lesions enhance with contrast while the blood-brain barrier is still open. And then once the brain heals it, it shuts off. So in ADEM, because the inflammation happens all at once, you will see big bad lesions like that. But along with that, you also see that all of the lesions enhance with contrast. So even though they may meet the criteria for MS, because all of them are enhancing, it's a one-time event, it is more likely to be ADEM than MS. And why do we have to keep trying to differentiate ADEM from MS? Now, ADEM is often a one-time thing. So after you treat the acute event, whether it's with steroids or IVIG or Plex, you don't have to put these patients on long-term immune suppressive treatment. On the other hand, if you're diagnosing MS, what you're implying is that this is a recurrent disease. So even after the first event, you're going to start them on an immune suppressive treatment so that they don't have any further relapses. So these are the differences between MS, or what we call the first attack of MS is called clinically isolated syndrome. It's essentially just MS and ADEM. MS is, common in adults. Pediatric presentations can happen, but it's uncommon. While ADEM, most of the time it's in kids, especially if they've had a prior infection or vaccination within a week or a couple of weeks, they present with this kind of thing. In terms of cognition, MS, it doesn't affect cognition. In NMO, in ADEM, because they are big lesions that affect the cortex as well, they can tend to have cognitive effects too. We looked at the MRI lesions. What about CSF? Usually in MS, the protein and cell count are normal or just mildly elevated, while you more than 95% of the time you'll have oligoclonal bands and IgG index. In ADEM, often because there is so much inflammation, the cell count and protein can be higher than MS, and the presence of oligoclonal bands or IgG index tends to be lower. So, if you're in doubt, you collect all of these things, which can help you make one diagnosis or the other. Now, this is a relatively newer entity, which is called myelin oligodendrocyte glycoprotein, or MOG antibody disease. It's important to recognize this because the treatment for this is different from MS. So a patient can present like MS, but more often MOG patients present like NMO. They often have recurrent optic neuritis or transverse myelitis, but the NMO IgG antibody is negative. Those are the kind of patients that might end up having MOG. Earlier, even before NMO was identified in 2004, we treated NMO as a subtype of MS, called it opticospinal MS. Same way, I guess we have been including MOG into the MS group until now, till the identification of this particular antibody. And now it's like, you know what, this is an even separate entity. The way you would diagnose this is not a one-time elevated MOG, because sometimes when there is a lot of acute inflammation in an MS lesion, you can have antibody for MOG positive. It is sustained, so you repeat it, and if it hasn't gone down and it's still high, that's when you would diagnose somebody as having a MOGAD or MOG antibody disease. Now, what about, patients who have these changes on MRI but don't have MS, especially now that our threshold for getting an MRI has become very low. Often patients who have headache or were involved in a car accident or fell down, we want to make sure we're not missing anything, so we get an MRI very easily. So now we are going to be seeing more and more of this, patients who have these white spots, and then we are stuck with figuring out, is this MS or is it not? So this was an older study, and they actually looked at fairly younger patients, like less than 55. And even in that patient population, 60% of them had at least one spot. So now if you look at an older population, more than 60 years, the incidence of finding things like this is going to be very, very high. You're going to see one or more of these spots on the majority of these patients. Just because they have a lesion in the white matter doesn't make it a diagnosis of MS. So we have to really be able to talk to patients or review this and think this is not MS, because we are seeing a lot of patients who get referred to us for lesions like this because they fell or they had a headache or didn't feel well. Going to the other end of the spectrum, same thing. Now that we are getting MRIs, the threshold for MRIs has become so low, we are going to be doing MRIs and finding that they have MS, an MRI brain that looks just like MS, similar to those initial MRIs that I showed you, those ovoid lesions perpendicular to the long axis of the ventricle. So for all purposes, they have MS, but clinically, they haven't presented with a relapse or anything like that. The MRI was done, again, for things completely unrelated to the lesion, because they, had a headache, were in an accident, fell down, nothing to do with any MS symptom. So what do we do with those patients now? Now, they have MS, it's just that they haven't developed any symptoms, maybe because their lesions didn't happen with in a fulminant manner, or they didn't develop lesions in the spine or brainstem, which tends to be symptomatic. How do we treat those patients? Are we going to just keep waiting till they keep accumulating these lesions and at some point manifest some symptoms? And at that point, it will be too late to reverse what has happened over the years. So this was, again, one of the earlier studies to 2009. They looked at patients who had got an MRI that was consistent with MS, so it's called radiologically isolated syndrome, and then followed them for about 3 years. And, a quarter of these patients ended up having a symptom. Then you called it MS after about 5 years. Patients who were younger, male, and especially if they had spinal cord lesions, they tended to develop MS. But we cannot wait for patients to have symptoms before we start treatments, because all our treatments are very good in the early part of the disease. They keep becoming less effective as time goes on. So how can we make a decision regarding treatment early on? Like so much of medicine, there is no consensus as to how we approach radiologically isolated syndrome patients. Do we treat them? What is our threshold for treating them? But most people will agree that if you got an MRI that looks like this and you repeated it in 6 months or a year, and they developed a new lesion, even if clinically they haven't changed, then you would treat. Or maybe if they have a lot of GAD enhancing lesions and you've ruled out other things. So there is no, 100% guideline as to what to do. But if there is radiological progression, you would definitely treat. If there was GAD enhancing lesions, then you might monitor them a little more closely. But the bottom line is you don't leave these patients alone. You repeat the MRI at a bare minimum. Even if they don't have clinical symptoms, you would treat at some point. With regard to the types of MS, it's important to know the type because the relapsing form of MS is what responds very well to treatment. Progressive MS doesn't respond very well, though some of the treatments have an indication in progressive disease, they really don't help that much. And all treatments work well in the early part of the disease, they don't work well as we go on. So this is kind of a cartoon of what happens in MS. In relapsing patients, the patient might have a relapse, their problems go up and then they get down. So it's an up and down pattern. If you follow relapsing patients long enough, especially patients who have not been treated effectively in the beginning, that up and down pattern changes to one where they are slowly getting worse, and that is called the progressive phase. Primary progressive is the less common form of MS, which is usually diagnosed in patients in their late 40s or 50s. And the sex ratio in this tends to be 1:1. So especially, for board questions and things like that, if they want you to choose relapsing remitting, they're going to give you a 25-year-old woman. If the answer is primary progressive MS, they're going to give you a 50-year-old man because the slightly higher incidence in males compared to the incidence in relapsing remitting, and they are diagnosed a decade or two decades later than the relapsing patients. The way one would distinguish between secondary progressive and primary progressive is in secondary progressive, they have a preceding relapsing phase and then they change to progressive, while in primary progressive, they never had that. The disease started with slowly progressive disease. So it's not like a test based on an MRI or spinal tap that helps you distinguish. It's the patient's history. What about MS treatments? So you can divide that into what do you do in the acute phase and then what is their long-term treatment. So what is a relapse? So a relapse is a new symptom which lasts at least 24 hours. And patients usually recover from a relapse over the next 3 to 4 weeks. It's important because there are things that cause a pseudo relapse, which is not a true relapse. So what causes pseudo relapses? One is symptoms that get worse with heat, humidity, fatigue, stress. They are not relapses. So patients with MS have very poor heat tolerance. So when it's hot and humid, especially 3 or 4 weeks ago, a lot of our patients came in complaining that their MS symptoms were weak, were worse. Patients who are very fatigued, patients who are stressed. The reason to distinguish that is if you just give them steroids, it's not going to take care of it. You have to address the underlying problem, especially if it's caused by infection. So if a patient is feeling worse because they have a UTI and we give them steroids, it's going to be counterproductive because steroids can make their infection worse. So we need to be able to distinguish so-called relapse from a pseudo-relapse. The last thing is an MS patient who is in the progressive phase, their symptoms getting worse is often not a relapse. If it happens slowly, it's just their disease progression. If it happens acutely, it is because of an infection or one of the other factors I had mentioned. Once you confirm that this is a relapse, what do you do? The typical treatment for an MS relapse is IV steroids, anywhere from 3 to 5 days. We use oral prednisone or ACTH if they cannot tolerate the steroids, if they don't have IV access or insurance issues, but we very rarely use that. For most part, everybody with a relapse gets steroids. Now, if they don't respond to steroids, IVIG or plasma exchange is used. And this is often the case with NMO patients. MS patients usually respond to steroids very well. Moving on to long-term treatment, I don't want to go over every single one of them and confuse you guys, but you have a whole bunch of treatment. They vary from mildly immune modulating drugs to immune suppressive medication, and we have to kind of try to find the best fit for the patient, depending on the patient, how aggressive we need to be to control their disease. If you took away one thing, it is this slide. We have so many treatments for MS now, but they all address the immune system. They all control or suppress the immune system so that patients don't have any further problems. Unfortunately, they are not treatments that bring back neurons that are gone or go and remyelinate the whole thing. So in the early part of the disease is where you have relapses, inflammation, you have GAD enhancement. This is where treatments work. In the latter part of the disease, you don't see new lesions, even if a patient is getting worse, because it's the neurons dying, there is atrophy, there is not that much inflammation. It's almost like the MS is burnt out. But because of all the damage it caused in the beginning, it's causing problems with gait or cognition, and our treatments really don't work. So it has to be very front-ended. We have to be aggressive, treat patients optimally in the beginning. So we are not going to be choosing treatments blindly. So what are some of the prognostic factors that we can use in terms of determining what is the best treatment or what level of immune suppression that patient might need? One is the early disease course. So if a patient, even when you saw them within a year, they have 3 relapses, back-to-back relapses, they are going to maintain that pattern. Same thing, recovery from a first relapse. If a patient did not recover well from a first relapse, they tend to repeat that for their subsequent relapses as well. So they're going to be accumulating baseline deficits faster. Age at onset, that for relapsing patient, it may not be so relevant, but since it's the older patients that get diagnosed with progressive MS, often older patients are told to have or believed to have a worse prognosis because they're starting out with problems with gait. Initial symptoms, I mentioned, patients who end up having brainstem or spinal cord symptoms and lesions there, again, tend to repeat that pattern. And you cannot compensate that well versus supratentorial lesions, which you can compensate well. So they need to be treated more aggressively. Gender, because primary progressive is more common in the male population, that is, can cause more problems with gait. Race is another thing. African Americans have been shown to have a worse prognosis, both in terms of how they do clinically and on MRI as well. And the last one, time to second relapse, is like the initial point. If patients are having back-to-back relapses, they tend to do poorly. So how would you decide, okay, this patient needs a more aggressive immune suppressive treatment? What are the risks for a poor prognosis? One is a devastating relapse beginning, high relapse rate. And apart from how they present clinically, you look at the MRI, and even if they have recovered well, you look at the MRI and there are so many lesions, they tend to not do very well. So maybe even if your exam looks good, they have recovered from their relapse, if their MRI looks bad, you're better off going on a more aggressive treatment. Same thing, rapid onset of disability because they didn't recover from their first relapse. And like I mentioned before, African Americans tend to have a higher disease burden than Caucasians. So since many of you work in the hospital, I just put together a couple of slides as to when a patient might come to the ER or get admitted to the hospital. One is, if they have a really bad relapse, especially patients who are not diagnosed, they don't know what they have. So even if they have a milder relapse, they're going to come in because they don't know. Second reason a patient might come to the ER is because they have progressive MS and now their symptoms are worse. most likely because they had an infection, they had a fall, they were fatigued, stressed out, and that made the symptoms worse. Third thing is maybe related to some of the immune suppressive treatments they are taking. So what kind of, how does what the patient is taking medication, impact a patient's hospital visit? One is infections, because many of them are immune suppressive treatments. Patients end up having UTIs or, upper respiratory tract infections or even pneumonia and end up in the hospital. These patients usually tend to be progressive patients because they are older, they have underlying disability, so their immune system is weaker too. So they are more vulnerable to these kind of infections. That will make their walking worse, and they end up in the hospital, not because they have a true relapse, not because they need steroids, but because these need to be treated and they get decompensated. Uncommon, again, immune suppressive treatments are associated with opportunistic infections like PML, herpes encephalitis, but these are rare. Patients who are in immune suppressive treatment are going to get common infections more commonly. These are rare, but with specific treatments, it's good to keep these in mind. With some treatments like Copaxone or Glatiramer, it can have an immediate post-injection reaction. The patients develop flushing, palpitation. It may seem scary to them, but it's harmless. But I've had patients show up to the hospital because of that. And then you have Tecfidera Vumerity, which is a pill you take for MS. It can also cause flushing or GI symptoms that end up in the hospital. But neither of these things are dangerous. The things that one should not miss are most importantly, the infections that are making MS symptoms worse in a progressive MS patient. Why might patients get admitted to the hospital? One is new patients because they don't know the diagnosis. Or I've seen patients where they had these symptoms, nobody took them seriously because their exams seemed to be okay. And they've already gone on for like a month. Recently, I saw a patient who had this vertigo and problems with balance and some obscured vision. And people were just like, brushing her off. And I had to bring her into the hospital, though she wasn't like in acute stress, because this had gone on for a month. And before we diagnose her, it's going to take another 2-3 weeks if I order all these MRIs as outpatient. So we brought her in, and she ended up having a GAD enhancing lesion in the brainstem, which is what causing her vision problems and vertigo. And we gave her steroids, and she's much better. So, sometimes patients with MS can have relatively vague symptoms that one cannot put a finger on, and it's like, they that delays their diagnosis because it's attributed to them being crazy or psych issues. So we have to be aware of that too. Another reason a relapsing patient might end up in the hospital is because their relapses are bad, that cause problems with gait or cannot see, or because we think they might benefit from rehab after the acute treatment. But for most part, relapsing patients who have a relapse, we manage them as outpatient. We can do steroids as outpatient. We can even do home infusions, or they come as outpatient to the MS center. They get their infusions, go home. So a lot of times, you guys or even residents who predominantly do inpatient, they don't have much of an MS exposure because it's predominantly an outpatient practice. The only instances where they end up in the hospital are due to these reasons. So that's why, I emphasize the other part, because it's good to know that not just what happens to them in the hospital. So again, most relapses are managed as outpatient, but if it impairs their ADLs, gait, vision problem, and if they'll benefit from rehab, they end up in the hospital. The third group of patients who come to the hospital are progressive patients. Now they have a UTI or a pneumonia, their symptoms are worse, and they think they're having a relapse. But we know that these patients don't have acute relapses like this. It's because something else is going on that is decompensating them, making their MS worse. So we have to be especially aware of that and work up for infection for these patients. I think that's my last slide, and I will stop there. I kind of rushed through this. I'm happy to take any questions if you have.